All right, everybody. I want to welcome you back to the Biochemical Genetics Clinical Core Seminar Series. This is week 2, July 26, 2024, and we're happy to welcome back Dr. Nicola Longo, Division Chief at UCLA. He's going to be talking more about fatty acid oxidation, so we're excited to hear the conclusion of his lecture from last week. If you missed it, as always, everything is archived on the SIMD website, so you can go back and hear that. We are probably going to be posting PDFs. Dr. Longo, could you possibly send us the
Yeah,
PDFs, please, too? Okay,
you have PDFs of both lectures.
perfect. Okay, I'll make sure those get posted along with the lectures, too, so you can take notes as you need. Just a couple of housekeeping things. We'll have more time for questions at the end, so you can chat in the chat if you want. But if you want to ask Dr. Longo questions, probably good to save them to the end of the lecture. And we have CME credit. Sarah just posted in the chat the code you can use if you want the CME credit. It's 1.5 CME hours per lecture. You can continue to follow along with the series and get up to 35 hours for the series this year. So I think with that, I will give it over to you, Dr. Longo, and let you go on with your talk.
Thank you very much, Pete. So my name is Nicola Longo, and I'm a clinical and biochemical geneticist at UCLA. I was formerly at the University of Utah, and these are my disclosure. And what we are going to do today is to complete the lecture on fatty acid oxidation. And what we saw the first time is that the liver function is to produce a lot of ketone bodies. And today we are going to discuss on disorder in which the body cannot either synthesize or utilize ketone bodies. So the objective of the discussion today will be to understand why and where ketones are synthesized, to define the enzyme involving ketone synthesis and utilization, and then list therapy for disorder of ketone body synthesis and utilization. Now, why are ketone bodies important? Ketone bodies become very important during fasting and other conditions in which there is lipolytic stress, conditions in which you burn down fat in adipose tissue. And most of them derive from the oxidation of fatty acid, but also from ketogenic amino acids such as leucine, lysine, and isoleucine. They're usually produced in liver mitochondria. They are transported to extrahepatic tissue where they are utilized. And ketogenesis and ketolysis are important processes, especially for the brain. The brain can utilize glucose and ketones. If you take away ketones, then the brain starts suffering. And obviously, this is important when there is not much glucose, for example, during fasting. And physiological ketones level in blood range from almost undetectable to about 6 millimolar in physiological conditions with prolonged fasting. In diabetic ketoacidosis, they can become even higher and obviously result in severe morbidity and mortality, possibly in that condition. And most of the ketone bodies are taken up by extrahepatic tissue, and some of them are lost in the urine during ketosis, and those are the ones that you detect when you do the stick, or when you do the urine analysis that has a detector for ketone. Keep in mind that the detection in the urine analysis kit is not very sensitive. Urine organic acid are more sensitive to detect ketone bodies. Now, we have been talking about ketone bodies, but what are ketone bodies? So in this slide shows that 3 compounds that we usually define as ketone bodies. The one that it is generated by metabolism is acetoacetic acid, and this can be converted to beta-hydroxybutyric acid or 3-hydroxybutyric acid. those are the same thing. And they can go back and forth and be utilized by the body interchangeably. Also, there can be decarboxylation of acetoacetic acid that can generate acetone, which is the one that you smell in people who have a very ketotic. So the smell that you feel is the one of acetone. Now, how do we utilize ketone bodies? Basically, the more we give them to tissue, the more they utilize them. So ketone bodies are very easily utilized by the tissue. And the heart and the kidney are the organ that has the greatest capacity of utilizing ketone bodies. And the ketogenic pathway, which is the one that provides fat-derived fuel for the brain, is important for when glucose is low. And patients with defect in ketone synthesis or degradation are asymptomatic unless they are fasting. Like in fatty acid oxidation disorder, what happens is that if you do not need energy from fat or you don't need energy from ketone, you are usually asymptomatic. How do they present? Defect of ketogenesis, you cannot synthesize ketone, and you have hypoketotic hypoglycemia in a manner very similar to the one that you see in fatty acid oxidation disorder. Disorder of ketolysis, the ketones are released, but the body cannot utilize them. So what you will have ketoacidosis that can be severe, and there can be hypoglycemia, but not always. Let's review a second what happened during fatty acid oxidation. As we discussed at the previous lecture, during fatty acid oxidation, during fasting, fatty acid will be released from the adipose tissue and reach all organs in the body, including the liver, the heart, and the skeletal muscle. In the heart and in the skeletal muscle, fatty acid will be completely burned down to produce energy. So they will release CO2 and water in addition to energy. In the liver, there will be a partial fatty acid oxidation with the generation of acetyl-CoA. Two molecules of acetyl-CoA will combine together to form acetoacetyl-CoA that will then give rise to the production of ketone bodies. The ketone bodies are beta-hydroxybutyrate and acetoacetate. They will be released by the liver and they will reach all organs and tissue. Fatty acids are not able to reach the brain, but ketone bodies are. So ketone bodies in the brain that can provide energy to the brain to provide energy even during time of hypoglycemia. So what happened in fatty acid oxidation disorder? In fatty acid oxidation disorder, the liver will not be able to release ketones, and obviously there will be increased utilization of glucose by all organs, leading to hypoglycemia. And at the same time, the brain will not be able to have any energy for which you suffer loss of consciousness. That can proceed to coma, and that if no intervention is done. Now, what are the steps in ketogenesis and ketolysis? So there are two mitochondrial enzymes that are 3-hydroxy-3-methyl-butyryl-CoA synthase and 3-hydroxy-methylbutyryl-CoA lyase that are necessary for the production of ketone bodies. For the utilization of ketones, you need three different reactions. First of all, you need a membrane transporter, which is the monocarboxylic transporter 1 or MCT1, that is responsible for the entry of ketones into tissue. Once they are inside, you do the reverse of the reaction done in the liver. So first you need to activate the ketones attaching coenzyme A by the action of succinyl-CoA 3-ketoacid oxoacid transferase by the enzyme SCOT. And then you have a beta ketothiolase, which is the one responsible for the utilization, for the breakdown of the ketone. Deficiency of the first two enzymes causes disorder of ketogenesis. Deficiency of the transporter, SCOT, and beta ketothiolase will cause disorder of ketolysis, and all are inherited as autosomal recessive traits. Now, where does ketogenesis occur? Ketogenesis occurs in the liver. There are several studies that show the expression of the gene responsible for ketogenesis, and these are expressed mostly in the liver. What do they do, this enzyme? So, as we discussed previously, we have that the breakdown of fatty acid will generate acetyl-CoA. Two molecules of acetyl-CoA will combine to generate acetoacetyl-CoA. At this point, 3-hydroxy-trimethyl-CoA synthase will attach another molecule of acetyl-CoA to generate hydroxy-methyl-glutaryl-CoA. At this point, this molecule is very big and attached to coenzyme A, so it will not be able to leave mitochondria. So at this point, the 3-methyl-3-hydroxyglutaryl-CoA liase will release acetyl-CoA and generate acetoacetic acid that will be able to exit mitochondria and the cell. To this reaction, which is the hydroxy-butyryl-CoA dehydrogenase, 3-hydroxybutyric acid and acetoacetic acid are converted into one another. So obviously, both of them can be exported, both of them can be utilized by the cell. Again, this process, which is the release of ketones, happens in the liver. All other tissue, they utilize the ketone bodies. So they have a machinery that allow them, first of all, to take up the ketone bodies through the action of this monocarboxylic transporter 1. Once the ketones are inside the cell, what you do, you attach a coenzyme A to the ketone body, so this derives from succinyl-CoA, and then you generate acetoacetyl coenzyme A. At this point, what you do, you utilize one molecule at a time for in the Krebs cycle to produce energy, but this occurs by the action of beta ketothiolase. So this is the process that occurs in human and give rise to the utilization of, to the production and utilization of ketone. Now, most of these reactions are specific for ketone bodies, but there are some reactions that are common between the metabolism of ketone and the metabolism of branched-chain amino acids. As I told you previously, there are amino acids that are ketogenic, and there are isoleucine and leucine. The importance of this pathway is, on one side, obviously they can contribute to the production of ketones, but also they can generate some of the metabolites that we can detect in the urine or in plasma to tell us that there is a problem with with ketogenesis or ketolysis. So, for example, beta ketothiolase is required not only for the utilization of ketone, but also in the breakdown of leucine. And when this is defective, you can have the accumulation of this chemical, which is 2-methyl-acetoacetyl-CoA, that then can, from which some other metabolite can occur. Again, beta ketothiolase will generate acetyl-CoA that then will enter the Krebs cycle or give rise to the synthesis of ketones, depending if it is in the liver or outside the liver. In the metabolism of leucine, you have that the 3-hydroxy-trimethyl glutaryl-CoA liase is also responsible for one of the last steps of the utilization of leucine. As a result, if you have a deficiency of this enzyme, you may have the accumulation of 3-hydroxy-3-methylglutaric acid, which is shown down here. So this is, again, important for two reasons. Some amino acid contribute significantly to the synthesis of ketone. Second thing is that some of the metabolites that we see in this condition derive more from the catabolism of amino acid than from the breakdown of ketone. Now, how do disorder of ketogenesis present? Let's look at the first one. The first one is the mitochondrial 3-hydroxy-3-methylglutaryl-CoA synthase deficiency. It is extremely rare, even though probably it is very undetected. What I mean is that many of these patients have very few diagnostic metabolites unless they are stressed, for which they can be missed by metabolic testing unless you obtain a sample during the acute attack. How do they present? They present with hypoketotic hypoglycemia, metabolic acidosis, encephalopathy that can progress to coma after fasting or infection, hepatomegaly. They can present with or without hypoglycemia. So basically, there are very few signs, except that these people pass out and they look very sick, and they are very sick. What do we see during acute attack? We have elevated level of serum free fatty acid and triglyceride at time of hypoglycemia, and sometimes even when there is no hypoglycemia. They tend to have low HDL cholesterol. From a metabolic standpoint, they can have elevated acetylcarnitine, but acetylcarnitine may be completely normal. During the acute attack, they can have a decarboxylic aciduria. The presence of this chemical, which is 4-hydroxy-6-methyl-2-pyrone, and again, decarboxylia with the ketones that are absent or barely present with a normal life. The diagnosis can be established by DNA testing, and the therapy is relatively simple. We tend to avoid fasting, and we can give a complex carb, such as cornstarch, when we expect fasting, for example, before bedtime. Let's go back a second to the pathophysiology of this condition. So what we have that the fatty acid are unable to be conjugated with another molecule of coenzyme A, and basically they will accumulate at this point. What is the result of this action? The result of this action that you will have an excess of acetyl coenzyme A. We will not be able to be attached here, but will be conjugated with carnitine. For this reason, you have an increase of acetylcarnitine. The second thing that will happen is that since you generate no ketone, usually these ketone bodies can conjugate with carnitine to generate hydroxybutyryl carnitine, or what we call a C4OH, which is 4 carbon atom with an hydroxyl group attached to carnitine. So that one will be low, and the acetylcarnitine will be elevated in this condition. The second thing that happens is that you will have that all of the fatty acid will be released from the adipose tissue and generate this, what it is called a decarboxylic aciduria. Adipic, subaric, and sebacic acid will be elevated in the urine organic acid, or what we call the decarboxylic aciduria. At the same time, you have lack of formation of ketone bodies. Ketone bodies are in this part, on the left part of the chromatogram. So you have low or no ketone in the presence of severe decarboxylic aciduria. You also have the presence of abnormal urine organic acids, such as the 4-hydroxy-6-methyl-2-pyrone here in the urine organic acid. You can see some additional hydroxylated fatty acid, organic acid that are listed in this slide. but the one which is characteristic of this condition is this one. Now, why do we get this type of decarboxylic acid? The reason is that since you impair somehow beta oxidation, the fatty acid, instead of being directed to the mitochondria, they will be directed to the microsome. They will undergo omega oxidation from a fatty acid that has a COOH in one extremity. You will have shortening of the fatty acid and plus the formation of the carboxylic fatty acid, that it is the one that it is detected in the urine. So, in summary, what you get in this condition, which again it is called 3-hydroxy-3-methylglutaryl synthase deficiency, you will get abnormal urine organic acid, which are present at the time of acute attack with metabolic acidosis. You can get an elevation of acetylcarnitine with low level of C4H or 4-hydroxybutyryl carnitine. But again, if these patients are fed, you have no biochemical abnormality that give away these results. So that it is why this disease might be missed by biochemical testing and need to be tested by DNA testing to arrive to a diagnosis. The second condition that can cause a disorder of ketogenesis is deficiency of 3-hydroxy-2-methylglutaryl-CoA lyase. And this condition usually present early in life with vomiting, seizure, encephalopathy, and hepatomegaly. You can have hyperammonemia, acidosis, an increase in ion gap, elevated transaminases, and hypoglycemia. The organic acid can show a host of abnormal organic acid with increased excretion of 3-hydroxy, 3-methylglutaric acid, 3-methylgluconic acid, 3-methylglutaric acid. And you will notice that all of these derive from the breakdown of branch chain amino acids, isoleucine and leucine. You may have other abnormal organic acids, such as 3-hydroxyisovaleric acid, 3-methylglucosyl glycine. And then in the plasma carnitine profile, you can have elevated 3-methylglutaryl and 3-hydroxyisovaleric carnitine. So, and these are known also as C6-DC carnitine, C6-decarboxylic carnitine, and C5-hydroxyl carnitine, or C5OH carnitine. The increased concentration of these two acyl carnitine can enable the identification of this condition by neonatal screening. The diagnosis is confirmed by DNA testing. The therapy here is a little bit more complicated. These children can become sick, especially if they have a severe deficiency. The therapy here is again with fasting avoidance. We need to give carnitine because it can become secondarily depleted in this condition. You give a moderate protein restriction to decrease the content of isoleucine and leucine in the diet. You reduce the fat calorie, usually after the first year of life, to less than 30% of total caloric content. And some of these patients require cornstarch supplement at night before going to sleep. Now, what do we see in the lab? We have seen an elevation of the C6-DC carnitine, which is shown here, 402.57, C5OH carnitine, 318.6, and this is pathognomonic of this condition. Now, in the urine organic acid, you see all of the abnormal urine organic acid, but some of them really are very high. You can see the 3-methylglutaconic acid here that has a big peak, the 3-hydroxy 3-methylglutaric acid, which has also a big peak. You see the 3-methylglutaric acid here, and the 3-methylglutaconic acid also can be seen well. They are not always so high. So, but basically you need to keep that in mind, that they can be present, and obviously they are more elevated if you stress the system. Again, why are they here? mostly because they derive from the catabolism of isoleucine and leucine. Not so the one derived from the catabolism of these amino acids are the ones that provide the biomarker for fatty acid for disorder of ketogenesis. Now, obviously, one of the ones that it is increased is C5OH carnitine, which is here, and there is a big differential in patients who have elevated C5OH carnitine. This is the algorithm derived from the American College of Medical Genetics. These are called ACT sheets that tell you what to do if you have an abnormal marker on newborn screening that it is abnormal. In this case, you have an ACT sheet for elevated C5OH. And there are many different conditions that can cause elevated C5OH carnitine. And every year we had a few new ones. But you can see that methylglutaryl CoA deficiency is one of them. Again, in general, it can be accompanied to elevation of C5-DC carnitine, but we have seen all possibilities. We have seen patients who have elevated only the C6-DC, patients who have elevated only the C5OH, patients who have elevated both, and patients who have elevated none of the above. Obviously, you need to be very watchful for this type of condition. Now, what we want to do now is to move a second to disorder of ketone body utilization. So what happened is, again, in the liver, we synthesize ketone bodies. They are released to the general circulation, and then they're taken up by the cell by the action of this monocarboxylic transporter 1. Now, what happens if this monocarboxylic transporter 1 is deficient? Obviously, you have a deficiency of ketolysis with the accumulation of ketone bodies. But also amino acids such as lactic acid. Is this important? Yes, this is very important because lactic acid is a good source of energy, especially during periods of fasting. Lactic acid is not a toxic metabolite. Well, obviously, if you get 50 millimolar lactic acid, that becomes toxic. But 2, 3, 4, 5, 6 millimolar is not toxic. It is important to know that it is elevated simply because it tells you that something is wrong in the metabolism of something else. But lactic acid by itself is not toxic. So what happened in this condition? These conditions are very rare, not many cases reported. And what you have deficient transport of lactate, pyruvate, and monocarboxylic acid in general. This transporter uses the electrochemical gradient of hydrogen to concentrate monocarboxylic acid inside the cell. And obviously, the lack of ketones and lactate affect brain growth and function. So the presentation of this condition in terms of metabolic attack is episodic. There is no physiological or exaggerated physiological ketoacidosis. Some of these patients will develop the accumulation of lactic acid will cause tachypnea. They will start breathing very frequently to release CO2. They can develop lethargy, progressing to coma. They can have severe ketoacidosis with elevated anion gap. Some of these patients have cyclic vomiting. Most of these patients have psychomotor delay. They can have epilepsy or agenesis of the corpus callosum. In general, the tolerance to fasting improves with time, and they can have a resolution of the metabolic crisis after 8 years of age, at which point the neurological manifestation is when they become more evident. So how do we diagnose this condition? In this condition, what we see abnormal urine organic acid with increased acetoacetate and hydroxybutyric acid without abnormal urine organic acid. So in other words, we don't have a reason why are these elevated. So physiologically, in physiological ketosis, what you have elevated ketones, but also you have elevated adipic, suberik, and sebacic acid. So the fatty acids are released from the adipose tissue. They are metabolized to produce the adipic, suberik, and sebacic. So you see an elevation of those fatty acids plus the elevation of the ketones in physiological ketosis. In disorder of ketolysis, the fatty acids are released, but they are normally metabolized, so they will not become elevated. You will see the increase of ketones without the increase of the decarboxylic acid. The diagnosis by DNA testing, there are possibly milder variants in people who are heterozygous with this condition. So what they might develop a tendencies to ketosis. We still don't have the full story here. These conditions were just more recently identified, and we don't have enough experience to tell you if heterozygosity is just a risk factor or a disease in itself. The therapy for this condition is in the prevention of fasting, but also in the chronic administration of alkalis, such as citrate or bicarbonate, to prevent or reverse the acidosis. You can give a mild protein and fat restriction. You can use cornstarch, and sometimes you give carnitine, because again, the ketones will conjugate with carnitine, resulting in secondary carnitine depletion. Let's see a second what happened here. So what we are missing the transporter for monocarboxylic acid, such as ketone bodies and lactic acid. Obviously, when we have these compounds are essential for the production of energy in brain cells. If they are missing, not only we develop the metabolic acidosis, not only we have a defect in ketone utilization, but we have a problem in the brain. The brain cannot produce energy. And what you can see here, you can see the fact that there are enlarged ventricles which reflect suffering. You develop brain atrophy with time if you do not provide enough energy. And here you have a spectroscopy that shows mostly a lower N-acetyl aspartate peak, which just reflects the fact that the brain is not developed correctly. So this is the only condition among the one that we discussed where you can have a brain suffering, which is directly related to the pathophysiology of the disease. Obviously, you can have brain suffering in all of them. If you have prolonged fasting, that it is not treated appropriately. Obviously, if you have prolonged hypoglycemia, then you have secondary brain damage. But this condition can cause brain damage directly because it impairs the utilization of lactic acid and all of the monocarboxylic organic acid. Now, SCOT deficiency is the first disorder of ketone body utilization. In this condition, what you do, you cannot activate the ketone bodies. So the ketone bodies are released as 3-hydroxybutyric acid or acetoacetic acid by the liver. They are picked up by peripheral tissue, and then inside mitochondria, they need to be activated by forming a coenzyme A conjugate. So they will use the coenzyme A derived from succinyl-CoA to generate acetoacetyl-CoA. And then this one is the one that will be further metabolized by the Krebs cycle to generate energy. If the first enzyme is defective, you will have the accumulation of 3-hydroxybutyric acid and acetoacetic acid. So this gene is not expressed in the liver. Why? The liver does the other way around. They produce ketone. They don't use them. So if they need energy, they just burn more the fatty acid. So, but they are not able to utilize ketones from the periphery. It is a very rare disease. How do they present? They present with episodic, non-physiological or exaggerated ketoacidosis. Tachypnea, lethargy progressing to coma, severe ketoacidosis with elevated anion gap, persistent ketonemia even after eating. So physiologically, when you eat, you suppress the formation of ketone bodies. You are trying to store energy, not to use it. And that it is why the ketones are usually low when you are eating. In this condition, even if you are eating, you still produce minimal amount of ketone, but since they cannot be burned down by the periphery, they will accumulate and lead to metabolic acidosis and ketonemia and ketonuria. So the ketones here are present in the fat state. The diagnosis is made by urine organic acid. Again, what you have increased acetoacetate and 3-hydroxybutyric acid without other abnormal urine organic acid. Again, it is differentiated from physiological ketosis by the fact that you don't have elevated decarboxylic organic acid in the urine. The diagnosis is by DNA testing. We used to be able to obtain enzyme acid. This is no longer offered by any lab in the United States. The therapy is with prevention of fasting. You give alkali chronically to prevent acidosis. You give a mild protein and fat restriction, cornstarch and corn. I only had one case of this condition. That was a kid that was premature, remained hospitalized for quite some time at birth. We do not know exactly why. But then at age 8 months, the child was sent home and had to go back to the hospital because developed severe metabolic acidosis. And the way that they were treating this child is basically the child had to go be in and out of the hospital. The mom would bring the child in at night to undergo peritoneal dialysis to remove the excess acid. And people didn't know what was going on. The child was doing relatively well at normal mentality, but when I saw this child, I didn't know what the child had. But when we look at the urine organic acid, we saw the following. So what you can see on this slide, you can see that urine organic acid when the child was fed. And you can see that there was elevation of 3-hydroxybutyric acid and acetoacetic acid. The normal is less than 4. It was 6,000. And you see that adipic, subaric, and sebacic were totally normal. What happened when the child had severe metabolic acidosis? The ketones were even higher. Still, adipic, subaric, and sebacic were totally normal. This was the only indication that something was wrong with this kid that had to do with metabolic acidosis. Remember, at the time, getting DNA testing was not as easy as today. The activity of the enzyme of this kid was 0, and this child was homozygous for a single point mutation that caused the premature insertion of a stop codon. So obviously, we placed this child on alkali, on a special diet, and the child started doing well and didn't need to go to the hospital every night to get dialysis to remove the extra acid that was produced during daytime. So probably there are milder cases of SCOT deficiency as well, in which the ketoacidosis and the fasting develop only with severe stress. But this case was extremely severe, again, due to the fact that the child was homozygous for a stop. The last disease that I want to discuss today is deficiency of beta-ketothiolase of mitochondrial acetoacetyl-CoA thiolase. This has a ketolytic role, and basically what it does, it converts acetoacetyl-CoA into 2 molecules of acetyl-CoA. So the Krebs cycle utilizes one molecule of acetyl-CoA at a time, and basically what this enzyme does, it splits acetyl-CoA into two molecules of acetyl-CoA. So basically, when you miss this one, you can have different degree of severity of this condition, and we have patients who have complete deficiency of the enzyme, and this results in severe metabolic acidosis, again, usually triggered by fever or stress. In a complete SCOT deficiency, you are sick even without the stress. Here, you need stress or catabolism to have symptoms. But for beta-ketotidylase deficiency, we usually divide patients in two groups. One in which you have no residual enzymatic activity, and these patients usually you have biochemical abnormalities almost all the time. You have abnormal urine organic acid, and most of the time you have abnormal plasma acylcarnitine profile with elevated C5OH carnitine in addition to elevated T-glial carnitine or C5-1 carnitine. The patient with residual enzymatic activity, many times, they only have abnormal metabolite only at time of sickness. And sometimes I have a patient that have no abnormality even at time of sickness. So basically, this can be biochemically silent. And those are the patients who require only DNA testing for the diagnosis. There is an enzymatic test available, but this can give this, inconsistent results. And also as SCOT enzyme activity, this might not be offered by any lab at this point. The therapy here is more simple. Most of these patients do not need alkali supplementation. They tend to do well just with fasting avoidance, supplement of cornstarch or carb. This is a patient that I had many years ago, and he had a history of vomiting, lethargy, and the presence of hypoglycemia as well. Hypoglycemia is not constant in this disease, but can occur. 3+ ketones in the urine, metabolic acidosis with a bicarb of less than 5, and you can see the BMP on the right side of the slide, and an increase in iron gap. Now, this patient had a normal head CT. He was a poor eater, very active in his sleep. He was pretty skinny, and there are no previous hospitalization of surgery. He has a history of speech delay. So we suspected SCOT deficiency at the time. We obtained enzymatic assay because at the time it was easier to get that one than to do DNA testing. And what you can see is that the enzyme assay is very strange because what you have is that usually the activity actually was normal at baseline, but it could not be stimulated by potassium that physiologically double enzymatic activity. And basically here, one of the mutation that this patient had presented activation of the enzymatic activity. So what we did in this case, and let's see a second what we see in the urine organic acid, we were seeing the presence of the 2-methyl-3-hydroxybutyric acid, which is the characteristic of this condition. There are several other organic acids that can be seen, including 2-methyl-acetoacetate, which is characteristic of this condition. We saw an excess of the glial glycine as well, and the urine organic acid and the plasma acylcarnitine profile shows an elevation of C4OH carnitine, C5-1 carnitine, and C5OH carnitine. And you can see that the level of this chemical, especially C4OH, are much lower when the child is well. Here is the interpretation of the urine organic acid and the plasma acylcarnitine profile. That was the one that gave us the diagnosis in this patient. Why are these organic acid and isocartin elevated? Again, this enzyme has two jobs. One, to participate in the breakdown of ketones. The second one is to participate in the metabolism of isoleucine and giving rise to the abnormal metabolite that we see in the urine. Again, this one is one of the conditions that cause elevated C5OH carnitine, which is called BKT, beta-ketothiolase deficiency. Again, in most cases, you have a presence of an elevation of different isocarnitine. Our experience has been that some patients have elevated C5OH only, some patients have elevated C5-1 only, some patients have elevated C4OH only, and some patients have one-time elevation of one, sometime elevation of another, sometime elevation of another one. And keep in mind that the patients who have the mild variant can be very biochemically silent and you don't pick them up unless they are metabolically stressed. Even those patients, however, they benefit from PET therapy and they tend to do much better of cornstarch and fasting avoidance. So keep in mind that the kid that we diagnosed early on is now finished high school, is going to college. So basically giving the cornstarch therapy and the fasting avoidance improved the speech delay, made this child catch up with development. And now this child is in engineering school. So he's doing actually very well in school. So basically solving the case was important to not only to prevent the metabolic acidosis, but also to favor the development of this case. So in summary, we have seen that fatty acid oxidation and ketogenic amino acid produce ketones in the liver that can be used by the rest of the body to produce energy. Disorder of ketogenesis that are caused by mitochondrial 3-hydroxy 3-methylglutaryl-CoA synthase and lyase deficiency present as fatty acid oxidation defect with hypoketotic hypoglycemia. Hypoglycemia may not always be present. Disorder of ketolysis, such as deficiency of the monocarboxylic acid transporter 1, succinyl-CoA oxoacetyl-CoA transferase deficiency and beta-ketothiolase deficiency, present with acute metabolic acidosis during fasting. The metabolic acidosis is due to the accumulation of ketone bodies that are acid, and obviously they cause the metabolic acidosis. Urine organic acid and plasma isocarnitine profiles can identify abnormal metabolites in 3-hydroxy 3-methylglutaryl-CoA lyase deficiency and beta-ketothiolase deficiency. No diagnostic metabolites might be seen in the mitochondrial 3-hydroxy 3-methylglutaryl-CoA synthase deficiency, in SCOT deficiency, and in the MCT1 deficiency. Again, all of them have abnormal level of normal metabolite. They don't have any, pathognomonic metabolite. Again, you can have some of them in the synthase deficiency, but only during the time of acute attack. All of them require DNA study for diagnosis. Therapy consists in fasting avoidance, the administration of alkali in patients who develop the metabolic acidosis, and sometimes carnitine supplement because carnitine can become depleted in this condition. I want to thank all of you for your attention, but especially I want to thank all patients and their family and the people at my previous institution at the University of Utah that worked with me in elucidating the pathophysiology of some of these conditions. And I thank all of you as well for your attention. I'm open to questions. A question can come either live or by the chat. Thank you.
Thank you, Dr. Longo. That was fantastic. These disorders are notoriously squirrely, difficult to diagnose. So it's really, and clearly a diagnosis means a lot in terms of patient care, treating them right. So thank you very much for highlighting that and going through that. Questions for Dr. Longo?
And you can ask questions from the previous session as well, since we didn't have much time before. So fatty acid oxidation and ketosis, or lack of it.
Gabrielle Elizondo asks about life expectancy for these disorders.
Sorry, did you ask a question?
Yeah, Gabriela Elizondo is asking about life expectancy for these disorders.
Sorry, she asked about, say again, I couldn't hear you well. So let me look at the chat. Maybe
Sure.
I read it. No, here. Okay. Oh, the life expectancy. The life expectancy can be totally normal, especially for beta-ketothiolate. We do not much about the MCT1 deficiency because we don't have enough patients later on. The one that can affect significantly the most life expectancy is 3-hydroxythimethyl-glutaryl-CoA deficiency, because it can be very severe. Obviously, if you die during an acute episode, you die. But you know, if you manage it well, then you can do very, very well. How is cornstarch useful for other than for increasing the glycemia? So basically what it does is not just increasing the glycemia, is blocking catabolism. So once the body sends glucose, what it does, it tells to the body that, you know, you don't need to break down fat. So you slow down the breakdown of fatty acid and you minimize production of ketone. People have been using even the administration of ketones. The problem is, you know, in this condition, if you give ketones, they might be useful possibly in disorder of ketogenesis, but not much in disorder of ketolysis, where they would aggravate the problem. So ketones, they have a signaling effect. You give a dose that it is very low of ketones. You don't give enough ketones to provide energy for this condition, only enough to break down, to block the breakdown of fatty acid and to block the accumulation of either free fatty acid or other ketone. But again, complex carbohydrate, including cornstarch, what it does is slow down the breakdown of fatty acid. It reduces the need for ketogenesis. It reduces the need for ketolysis. It reduces the accumulation of ketone bodies. It reduces metabolic acidosis. So do you the question is whether we recommend the administration of alkali all the time or only when the patient is sick? We recommend the administration of alkali at all time, simply because there is always chronic ketosis. So basically, when you have the ketones that are elevated, two things happen. Number one, ketone suppress your appetite, mean that, you know, not only you are already in a catabolic state, you are in a condition that, you know, if you just go a little above that, you stop eating. And part of the suppression is due to the metabolic acidosis, and part of it is due to the ketones themselves. Without giving alkali, usually I like a polycitra, bicitra, this type of thing, or, you know, a balanced solution of sodium citrate that lasts a little bit longer, and it is more palatable than giving just plain bicarb. The second thing that I try to do, I give that multiple times per day, mean that, you know, with every meal, you give a citrate supplement as well, and sometime in between meals. The next question is, I mentioned hyperammonemia in one or more of these conditions. What is the mechanism of this? We believe that some of these, the organic acid that accumulate, they interfere with the action of N-acetyl glutamate synthase, meaning that you block the formation of N-acetylglutamate. N-acetylglutamate is an essential cofactor of carbamide phosphate synthase 1, which is the first enzyme of the urea cycle. So if you block that one, ammonia will not be removed from mitochondria, will accumulate, leading to hyperammonia. In terms of IV fluid, with some of these conditions affecting the mitochondria, do you recommend limiting dextrose concentration during fluid resuscitation, D5 versus D10? I recommend you need to give calories. You need to give D10, and the mitochondrial function here is actually normal once you remove the toxic metabolite. So the best way of removing them is giving glucose. Sometimes you might have to give insulin as well. But in general, if you give 1.5 times maintenance at D10, you don't need to give anything. The second thing, my standard solution, if you have metabolic acidosis, I substitute sodium chloride with sodium bicarbonate. So in an adult, you give D10, 150 milli equivalent sodium bicarb with 20 milli equivalent per liter of potassium acetate during the acute metabolic acidosis. In a younger child, you might give, instead of half normal saline, 75 milli equivalent per liter of sodium bicarb plus the potassium acetate. Remember to check the potassium before adding the potassium to the IV fluid, but you should give it, because as soon as you start correcting the metabolic acidosis, the potassium will drop. So do not wait for the potassium to drop. If the potassium is not elevated, then you put that in the IV fluid. Is carglumic acid approved in this condition? Have you ever used it? For this condition, no, because they respond very well just by giving IV glucose and IV bicarbonate. You don't need to give carglumic acid. So carglumic acid or carbamyl glutamate is used chronically in some of the organic acidemia, such as propionic acidemia. The reason that there is that in those conditions, those organic acidemia, both propionic and methylmalonic acidemia, you tend to have chronic hyperammonemia, and it is believed to be due in part to the suppression of the formation of N-acetylglutamate. Carglumic acid mimic N-acetylglutamate and can substitute as an essential cofactor of CPS1 and favor the removal of ammonia by the urea cycle. More.
Nicole, do you foresee the comeback of any of these enzyme assays?
Again?
Do you foresee these enzyme assays coming back online?
No, I mean, I didn't do that myself. And the problem is that you need somebody who is a real biochemist. We are losing biochemists, people who actually can do this kind of stuff. It would be nice because, sometimes you have a VUS and you have no idea what it means. And one of the questions, do you think that using C3DC divided C4OH may be a more sensitive analyte than C5OH to identify BKT deficiency on newborn screening? Could be possible, but usually it is C6DC that we have as a biomarker. But at the same time, there are some that are totally silent. I had a case in which only the DNA testing was able to do it. I tried to look at all possible ratios, and none of them really was abnormal. So some cases just require DNA testing. You just need to use your brain to put them in the differential diagnosis and get a panel that includes this type of gene. The beauty of next generation sequencing, you can have a bunch of genes and they cost the same if you do 10 or 20. I understand that it is good to think, but you can always think and then act. The next question, that if you are in an energy deficit, how can rhabdo isn't assigned with this condition versus the other fatty acid oxidation disorder like last week. They are not a sign of rhabdo is not a sign of this condition simply because what produced the rhabdo is more the accumulation of abnormal fatty acid within the muscle rather than the energy deficiency. So, and if you think a second, which condition give you the rhabdomyolysis? The number one are the long-chain fatty acid oxidation disorder, such as CPT2 deficiency, LCHAT deficiency, VLCAT deficiency, multiple acyl-CoA dehydrogenase deficiency. You can have that even in primary carnitine deficiency. Why? Because what you impair really in primary carnitine deficiency is the oxidation of long-chain fatty acid. So that it is the issue. They are the long-chain fatty acids that accumulate and some of their metabolites that cause the rhabdo. Not the lack of energy. Obviously, if you push that to a limit, it might happen, but not as much as the accumulation of the free fatty acid. But it was a very good question, like many of the others. Thank you for asking that. Is carnitine supplementation in MCAD in the setting of secondary carnitine deficiency? So last week, we discussed that people give carnitine in multiple acyl-CoA dehydrogenase deficiency. We do not know if it is useful or not. And the answer is yes. What MCAD deficiency does is cause a secondary carnitine deficiency. The very first patients with carnitine deficiency that was identified did not have primary carnitine deficiency, had MCAD deficiency. And actually that patient seemed to do a little bit better with carnitine, but also with fasting avoidance, which was the problem. We do not know, but I don't think that they ever stopped carnitine at that point because, they gave both of them. So.
Great talk, Nicola. It's Rich Shang. Can you hear me?
Yes, I can hear you very well. Thank you.
Wonderful. I have this 14-year-old male with HMG-CoA lyase deficiency that we picked up because he presented at probably infancy with like undetectable glucose when he got sick. Anyway, he's developmentally slightly delayed, but otherwise doing well. Like he still gets admitted 2 or 3 times a year, and he starts nauseous, and he vomited, and will start vomiting, and then after that he needs to go to the ER. And every time we think we give him a bolus and he looks good, if we send him home, he comes right back. So we always admit him now and give him at least D10 overnight, and keep him, make sure he's tanked up before we discharge him. He is on a low protein diet and cornstarch and low protein diet. Since the lyase is a liver enzyme, do you think a liver transplant would help this kid and prevent him from these recurrent emissions?
Yeah, a liver transplant definitely would help him. But at the same time, I would like to see a moment what else can be done. Is this the same that we see repeatedly at UCLA, or is another one?
It's over at Chalk. You got one at UCLA as well?
Yeah, same thing. So but I haven't seen this one yet. So I'm getting to see this one to see if I can try something alternative. Keep in mind that in many of these conditions, they tend to develop metabolic acidosis, that it is very labile. So before proceeding, the first thing I would do, I would try to add chronic citrate therapy to see if we can prevent or delay the repeated admission. That would be my first approach. But again, I haven't been given the opportunity to see this kid yet. So, again, I've been there for a month, almost. So, give me some time, then I will see if I can do something. If that doesn't help, then I need to think something different. So, I agree. So,
if it works, let me know too. Maybe I'll try it on my kid.
Yes. So, and that would be, we can put the cases together. So, and then at least adding something more to what it is already done for this patient. Thank you for bringing it up.
Thank you.
So one of the questions, do you recommend ammonia scavenger and arginine or scavenger only in hyperammonemia secondary to fatty acid ketone disorder? No, I do not. So the reason is that in general, hyperammonemia in this condition is only an acute event. You need to focus on treating the primary cause of the problem rather than the epiphenomenon. So, and usually when you get it controlled, you tend to control the hyperammonemia as well. So hyperammonemia in fatty acid oxidation disorder is not a consistent finding, only during the acute attack. And also the same in HMG-CoA lyase deficiency and sometimes in the synthase deficiency as well.
There was a question in the chat just above that, Dr. Longo.
Oh, what is your approach to giving carnitine in long-chain fatty acid oxidation disorder? Some avoid it. So the reason that it is avoided is because what they found is that usually when the long-chain acylcarnitine are higher, the patients are sicker. What the reality is that usually these patients, yes, they have increased long-chain acylcarnitine when they are sick, but they also have increased long-chain fatty acid that are the cause of the problem. So you might note similarity between the presentation of disorder of long-chain fatty acid with sudden death and sometimes muscle breakdown with primary carnitine deficiency. In primary carnitine deficiency, you have zero carnitine and you have the same symptom. Why? Because again, what it is the problem are not the long-chain acylcarnitine. The long-chain acylcarnitine actually are a mechanism by which you get rid of some of these abnormal fatty acid and organic acid. So for example, one thing that we started doing a few years ago was to study the acylcarnitine profile in urine. And basically, you use the urine to remove garbage in the form of long-chain acylcarnitine. So for example, in glutaric acidemia type 1, you have a huge peak of glutarid carnitine. You give carnitine, you generate glutarid carnitine, and that goes to the urine. Is glutarid carnitine the cause of the problem in glutaric acidemia type 1? No, I mean, it is glutaric acid and all of the other stuff, and that it is obvious to everybody. What it is not obvious that the same thing happened in long-chain fatty acid oxidation disorder. So given this premise, what is my approach? My approach is that these conditions are usually associated with secondary carnitine deficiency. The second thing that happened is that when I started practicing many, many years ago, many of the patients that I saw with this long-chain fatty acid oxidation disorder, they tend to have very, very low level of long-chain acylcarnitine, or very, very low level of carnitine, free carnitine. And they tended to go to the hospital and to stay there forever. When I started treating them, they started getting better with carnitine supplement. The dose that I give in primary carnitine deficiency is 100 milligram per kilogram per day, divided into 3 doses with a max of 1 gram 3 times a day in primary carnitine deficiency. Here I tend to give a max dose of 25 milligram per kilogram, which is a relatively low dose, just to prevent the deficiency and to favor elimination. Again, when I started giving low level of carnitine supplementation, my patients started doing better, but also, you know, I did a bunch of other stuff. I do not know if it was the carnitine supplementation or some of the other things that I started doing. And, but, you know, obviously, since I do not know, I try to continue to do what it is effective and until I figure out if it is worthwhile or doing or not. What I can tell you, I never had any problem in giving low-dose carnitine supplement. Again, this is about a quarter of the one that we give in primary carnitine deficiency, much lower dose. Do you recommend a diet restricted in leucine and isoleucine? So we do recommend mild protein restriction. What I mean for mild protein restriction is that, you know, many children, they take about between 1.5 to 2.5 grams per kilogram per day of natural protein. I like to go more on the 1.5 gram per kilogram of natural protein. So not severe protein restriction. I mean, vegetable, yes. How effective are we in pushing vegetable in children? Not that great, but we try, okay? What is the problem in GA1? Asking for a friend. So glutaric acidemia type 1 is an organic acidemia, and it is characterized, you haven't done it yet here, but it is a condition in which you have the accumulation of glutaric acid is somehow involved in the brain degeneration. What I think that the major problem is there is that glutaric acid is very similar to glutamic acid. Glutamic acid is one of the major neurotransmitters in the brain and detects to the NMDA receptor. And so it is the D-aspartate receptor. So it is a receptor for decarboxylic amino acid. Now, if you have a consistent stimulation of this receptor, then you can get that the cells are stimulated until they die. So you have what we call excitotoxicity. So what you want to do, you want to remove as much as possible glutaric acid from the system. And this is done through the diet. It is done through the administration of carnitine and to prevention of fasting, because when you fast, you obviously break down lysine and tryptophan from your natural protein. Lysine and tryptophan are the natural precursor of glutaric acid. The other thing that I do, to be honest with you, I started treating patients during the acute attack only with, not with inhibitors of the NMDA receptor, but rather with activator of the GABA receptor. And that type of approach, only during the attack, has been able to reverse a couple of issues in which patients started having dystonia and oculogyric crisis. So basically, I add to the emergency room letter to follow the type of protocol. I have to say that even with this therapy, some patients that I see them at birth, they already have brain damage from glutaric acidemia type 1. Not much I can do if at the first time I see them, they already have brain damage. So that's what I think is the pathophysiology. So a problem with glutamatergic stimulation of the in the brain. Yeah, and also Dr. Coughlin, he is the expert of lysine metabolism. He will be talking about it next week. Sorry to take away this from him. I apologize.
No, he's the one that asked the question. He was baiting you, Nicola. That was good though. That was a good explanation. And maybe a good transition. Does anybody else have any questions for Dr. Longo? And while you're thinking about it, Dr. Coughlin will be talking next week more about lysine and glycine metabolism, amino acid metabolism. So,
yeah, one quick question.
Go ahead, Barry.
Sorry, just on my side, it seemed like it cut out really quick, Dr. Longo, when you were saying what you add to the emergency letter for these patients. Can you just review that again really quickly?
So the patient with the metabolic acidosis, so when I give the D10,
I think
for the
GA1.
GA1 patient that you were just discussing.
Oh, the GA1. I didn't tell you what I specifically had. What I had baclofen and diazepam. So one is an allosteric activator of the GABA receptor, and the other one is an agonist. So the combination of the two seems the most effective. I started using it because I went to a patient in the hospital that she was dystonic, turning the head around and having the head, the eye up, and she was very irritable. And I have a patient with glutaric acidemia type 1 who is in his 40s, and I had to give a dose of diazepam that the pharmacy used to call me all the time because they say, you want to kill this guy. No, I want to keep him alive. So, and basically, given the irritability of this child in the hospital, I started adding diazepam and baclofen, and and she went backward. So, and then at that point, I did it again, and it worked in another one. Now, I mean, it sure might be a coincidence, obviously, I do not know, but giving them only during the acute attack seems to help, and the other thing doesn't have any side effect. In the past, what they try to do, they try to give anti-seizure medication, such as phenobarbital, to these patients on a chronic basis. It failed miserably. So I do not recommend that one, but I do recommend doing it in this way. So I think, but you know, that's what has been effective in our hand. And this
Thank
is
you.
obviously in addition to giving calories, the intralipid. Again, we are talking about glutaric acidemia type 1, okay? Don't give intralipid IV to disorder of fatty acid oxidation, okay? We are talking about something else, okay? We do standard dosing for those medication. Oh yeah, I look it up. I mean, they're not on my speed dial.
I'll also remind folks while we're waiting for any further questions, Dr. Longo is recruiting at UCLA. So if you're looking for a faculty position in sunny California, talk with Dr. Longo about it.
Yeah, especially starting July 2025. That would be the. We take you before. Don't worry.
That's great. It looks like the questions have slowed down. It's 1:15, but I think we could probably let out early if everybody's content with that. Thank you again, Nicola, for the great talks, great pearls that were in there, and everyone have a good weekend. Enjoy the Olympics. I'm really happy people tuned into this instead of the opening ceremonies that are happening right now, but I think you can catch them in prime time. So thank you very much, Nicola.
Thank you. Bye. 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 Bye.
Bye-bye.